all presenters and speakers to see if we can keep to the time, as we need to be back in the room for 2:30. Let me recognize our head table: Dr. Jarvis Barbosa, the Director of the Pan American Health Organization, Dr. Jimena Aguilera, the Minister for Health of Chile, Dr. Kevin Bernard, Minister for Health of Belize, Dr. Eritzel Santa Maria, the Deputy Director and National Director of Planning for the Ministry of Health of Panama, and Dr. Jaime Savreda, the Director of Human Development for Latin America and the Caribbean at the World Bank. We also have connected this afternoon Dr. Adriano Massudo, who is the Vice Minister of Health in Brazil, as well as many important members of the World Bank PAHO Lancet Americas Commission, who have been responsible for this wonderful work that we'll be presenting for you this afternoon. We do have some of our esteemed commissioners here as well this afternoon. Dr. Sarah Bennett from Johns Hopkins University, the Bloomberg School of Public Health, and Dr. Marcia de Castro, the Global Health and Population from Harvard T.H. Chan School of Public Health. And of course our co-chairs for the Commission, economist Christian Herrera from the World Bank and Dr. Ernesto Bascolo from the Pan American Health Organization. Let me also recognize Dr. Thais Avila, the Editor-in-Chief at the Lancet Regional Health of the Americas, sitting here beside me, and thank you, Thaisa, for all the hard work you've done to get us here today. So with that, let me invite Dr. Barbosa to open the event for us. Thank you very much.
Thank you, James. Good afternoon. Honorables ministras y ministros de salud, delegaciones oficiales de los Estados miembros de la Organización Panamericana de la Salud, miembros de la Comisión de Lancet y Regional Health Americas, socios y colegas. Es un honor acompañarlo hoy en el lanzamiento del informe No hay tiempo que perder, la resiliencia como piedra angular de la atención primaria de salud en América Latina y el Caribe. Este informe, elaborado conjuntamente por el Banco Mundial, la Organización Panamericana de la Salud y la Comisión de Lancet y Regional Health Americas, llega en un momento de máxima urgencia. Nuestra región es una de las más expuestas a crisis en el mundo. Huracanes, inundaciones, epidemias y los impactos acelerados del cambio climático ya no son la excepción, son la regla. Sin embargo, con demasiada frecuencia, nuestros sistemas de salud y en particular la atención primaria de la salud no han estado preparados para proteger a quienes servimos. La pandemia de COVID-19 reveló essa vulnerabilidade de maneira cruda. Em toda a região se interromperam serviços essenciais para a atenção materna, imunização infantil, manejo de enfermidades crônicas, entre outros. Famílias inteiras perderam acesso a cuidados vitais justamente quando mais los necessitavam. Isso não pode volver a ocorrer, nem com a próxima pandemia, nem com a próxima emergência, nem com nenhuma crise que devamos enfrentar. Sim, um fortalecimento da atenção primária da saúde como um pilar central de sistemas de saúde resilientes, o custo da inação será imenso. O custo humano é devastador. Miles de muertes maternas, infantiles e neonatales prevenibles, mais de 100.000 muertes adicionais por enfermidades não transmissíveis e milhões de embarazos não planeados. As projeções da Comissão indicam que um solo choque, com uma caída de entre 25% a 50% na cobertura de los serviços de primeiro nível de atenção e uma recuperação que poderia tardar entre 1 e 5 anos, teria um custo estimado de entre 7 e 37 mil milhões de dólares. Cada uma dessas cifras representam madres, niños, famílias em toda nossa região, cujas vidas estão em jogo se não atuamos. Os sistemas de saúde nas Américas seguem apresentando fragmentação em la organização de los serviços de saúde, centrados excessivamente em hospitais, com insuficiente inversão na atenção primária da saúde. Esse desequilíbrio genera ineficiências sistêmicas pronunciadas e as disparidades em matéria de saúde. Sempre são os mais vulneráveis, os pueblos indígenas, afrodescendentes, comunidades rurais, quienes encargam com o maior peso. Let me now switch to English. This is why resilience must become a political priority. Resilience is not a luxury. It is a foundation of health security, social stability, and economic growth. Failing to strengthen our primary healthcare system will inevitably cause the next crisis to disproportionately harm our poorest and most vulnerable communities. A resilient primary health care ensures the continuous provision of essential services, prevention, treatment, and care before, during, and after shocks. The good news is that we know what works. The Commission calls for reanchoring health system in strong primary health care, where prevention, continuity, and community trust build resilience. It urges to close financing gaps with sustainable investment, align resources to primary health care networks, advance reforms that reward quality and people-centered care, strengthen governance and community participation, and build a resilient health workforce with adequate numbers, decent conditions, training, and digital tools to reach every community. Colleagues, the message is clear. There is no trade-off between building stronger primary health care and building health systems resilience. They are synergistic and mutually reinforcing. Investing in resilient primary health care is not only a health imperative, it is also a political and economic necessity for stable, healthy communities. History shows that Latin America and the Caribbean is capable of enacting bold reforms and innovation. Today, we must summon the semi-political will. Let us commit to making resilience a cornerstone of primary health care to ensure the people of this region are protected by strong, continuous, and sustainable essential services through any future crisis. The cost of inaction is measured not only in billions of dollars, but also in lives lost. Investing in our people, economies, and future is the only viable path forward. Distinguished delegates and colleagues, the title of this report says it best. There is no time to wait. The time to act is now. Thank you for your attention.
Thank you very much, Dr. Barbosa, for those opening remarks. Now let me pass the floor over to Dr. Jaime Savreda for some opening remarks from the World Bank. Thank you.
Oh, thank you very much, James. Good afternoon to everyone. I would like to start by greeting everyone gathered here, ministers of health, members of the Directing Council, and distinguished delegates. And here in the table, Dr. Jarbas Barbosa, Minister Aguilera, from Chile, Minister Bernard from Belize, Dr. Eritzel Santamaria from Panama, and also want to say hello to Thais Avila, Editor-in-Chief, who has been partner in crime during the last 2 years in this endeavor that we're talking about today. I want to also agree the co-chairs and all the commissioners who made this report possible. And it's an honor for the World Bank to join the Pan-American Health Organization and the launching and the Lancet in launching this Lancet Commission report focused on primary healthcare resilience. As Dr. Barbosa was saying, Latin America and the Caribbean is in the path of many shocks. And unfortunately, despite that, our systems are still built around hospitals instead of resilient primary health care. COVID-19, the pandemic, exposed that weakness. With 8.5% of the population, of the world's population, we accounted for roughly 13% of cases and 30% of deaths. In many countries, essential services like maternal and newborn care, immunization, chronic disease management fell by between 20 and 50% for at least 2 years. And this, as Jarbas was hinting at, this cannot happen again. We need to prioritize primary health care. And as the report underscores, we must ensure that we invest in community-based teams, that we have reliable supply chains, digital tools, and a trained workforce ready for emergencies. The urgency to do this is both to improve the quality of care and also to be better prepared for any future shocks. The Commission asked the question, what if we do not do what we need to do, right? And the Commission tried to answer this question by modeling precisely the cost of inaction, right? And as it was said, as short shock could imply losses of about $14 billion. A shock that lasts longer, up to 5 years, could push the losses to about 35 billion, nearly 1% of GDP. And even those conservative figures translate into thousands of preventable deaths. So the question that we need to ask ourselves is, are we doing enough in Latin America and the Caribbean? And the answer, I would say, is not yet. Our region invests around 70.5% of GDP on average on current health expenditures, well below the average of OECD, which is 13%. And there is a wide variation within our region, from 3% in some cases to 12% in other cases. But in all cases, the issue is not simply how much we spend, but how we spend. Stronger primary health care and greater resilience are two sides of the same coin. And there are many things that we need to do in order to spend better. But I want to mention two things. The first one area that I need to mention is investing in people. Despite scientific progress, despite artificial intelligence, healthcare is intensive in human interaction. A robust health workforce is the backbone of high-quality primary healthcare. Yet many Latin American and Caribbean countries face shortages and maldistribution of health professionals in primary healthcare. Most of our countries lack sufficient primary care providers, especially outside urban centers. So investing in human health resources is absolutely critical. We need to care about the people who deliver the care. Investing in hiring, in supporting, providing professional development opportunities and incentives, using multidisciplinary teams and deploying efficiently and equitably health professionals. That is a massive and urgent challenge in many countries. And the second point I wanted to mention is that we need to invest better on digital health. The report reminds us that digital tools are now essential for care delivery, but their use must account for the vast digital inequities in our region. However, we know that used wisely, digital tools transform resilience. To give one example, Panama's Telesalud program expanded consistently between 2021 and 2024. In Sao Paulo, Avanza Saúde unified clinical data for 26 million people and logged 1.7 million teleconsultations. Costa Rica's digital health record now covers 90% of primary health care facilities. These are not pilots. These are initiatives that show that digital health, when done right, strengthens primary care and resilience. And this is just one example. The Commission's findings go well beyond technology. They call for PHC systems that integrate public health functions, empower communities, and secure sustainable financing. Just to conclude, strengthening primary health care is one of the greatest health challenges in Latin America and the Caribbean. The Commission's report is a roadmap that shows what works. But the hardest part is not technical. The hardest part is political. Is the need for governments to place primary health care at the center of their agendas, invest in it urgently and at scale, and ensure universal coverage. Protecting lives and economies cannot be optional. It must be a priority, and there's no time to wait. Thank you very much.
Thank you very much, Dr. Savareda, for those words. Now let me pass over to Dr. Thaisa Villa from the Lancet Health Americas.
Thank you, James. Distinguished guests, colleagues, thank you for the opportunity for us to launch it here. I would like to greet Dr. Jarvis Barbosa for being here, Dr. Saavedra, Minister Aguilera, Minister Bernard, and Dr. Santa Maria, and I was just gonna give some remarks from our side. It is a privilege to open the launch of this Commission report that was led by PAHO and the World Bank, and also a group of outstanding academic researchers from the region. As an editor-in-chief, I'm honored to witness our journal's first commission coming to life. A Lancet Commission is traditionally set out not to describe the world as it is, but to challenge the status quo and to ignite real and lasting change. And I expect nothing less from this one. The Commission stands out as a multidimensional approach, and it brings together academic analysis, community voices, practical implementation experience, and expertise in health and financing. In times like what we are living now, when the work of multilateral entities is being questioned and the value of international collaboration is under scrutiny, it is essential to highlight the power of multilateral approaches, as we're doing right now today. This Commission is a proof that when we work together across borders, across disciplines, we can produce solutions that are both ambitious but also grounded on the realities of each country and each region. It is also clear from the report that the ultimate goal continues to be a universal, free, and people-centered healthcare that is also resilient to shocks. It is not enough to just expand coverage in abstract. We must ensure that every person, regardless of income, geography, ethnicity, gender, or migration status, can access the care that they need when and where they need it without financial hardship. Our region, as my colleagues just said, is extremely prone to shocks, and we're not prepared for them. And the resilience primary healthcare is the only foundation of healthcare systems that can withstand the shocks, protect the lives, and promote equity, as we all want. But what's perhaps the most important point of this report is that every recommendation that you will read here is grounded in rigorous scientific research. And again, when science is sidelined and politicized, it's vital that we continue to let evidence guide our decisions. The expectation of a Lancet Commission, as you can imagine, is high. And we hope that this report can guide government, civil society, scientific communities, and move beyond the rhetoric to take concrete steps to build a resilient, equitable, and people-centered primary healthcare. I also hope that it will set a new standard for when we approach complex health challenges by bringing together diverse expertise, centering the voices on those that are most affected, and insisting on accountability and transparency at every stage. And the work doesn't end here. It actually starts today. This report is the beginning of a long path to a truly transformational reform of our health systems. Our job will be to support, monitor, and continue to report the progress, share the hardships, and learn from each other as countries, as entities, and as a journal. But before I close, I would like to acknowledge the extraordinary team behind this work that we're here from today. My deepest thanks to Christian and to Ernesto for the leadership, to all the commissioners for the rich and challenging discussions, to the entire authorship team for the commitment and collaboration for over 2 years of work, and also for the consultants and the secretariat that took all of these discussions, all our ideas, all of this continuous conversation, and put it into a very nice wording that you can hear today and read in the report. So this report is actually a testament that we can achieve a lot when we work together across the disciplines, sectors, and borders. We owe to these people here that the recommendations in this commission do not remain words on a page, but they become the foundation for a more just and resilient future for all of us in the region. It is an honor for the Lancet Regional Health Americas to host and support this work in our pages. Thank you.
Thank you very much, Dr. Villa, for those remarks. I want to thank all the speakers for their opening remarks. We'll now actually move to a short video of the Commission As you know, PAHO, the World Bank, and the Lancet Commission was actually launched in January 2024 to develop a comprehensive conceptual policy framework for primary health care and resilience, and to identify fundamental strategies and policies to develop and define the key investments that LAC countries could carry out. So with that, please, can we have the video to present the process and some of the initial findings? Thank you.
In Latin America and the Caribbean, health faces an increasing number of threats such as climate change, epidemics, as well as demographic and epidemiological transitions. How do we bring together science, public policy and financing to respond to these challenges? In January 2024, the Lancet Regional Americas Commission on Primary Healthcare and Resilience was established, an alliance between the World Bank, the Pan American Health Organization, and the Lancet Regional Health Americas. The mission of the Commission, comprising of experts from the region, is to generate practical evidence and issue a call to action to transform health systems based on primary healthcare and strengthen resilience to potential new epidemics, climate change, and natural disasters.
Esta comisión viene a recolocar la importancia de la atención primaria en salud en una región que ha tenido una larga trayectoria y que requiere su fortalecimiento y el apoyo político y de las comunidades para hacer una realidad.
The Commission estimates that a crisis reducing primary healthcare coverage by 25 to 50%, with a recovery period of 1 to 5 years, would impose an economic cost on the region ranging from $7 billion to more than $37 billion. The more conservative estimates indicate that such a disruption could cause over 165,000 additional deaths in the region.
Esta comisión pues es una gran oportunidad para poder llenar ese bache que hay en el conocimiento y poder dar recomendaciones que sean de utilidad para los países para tener un mejor sistema de salud.
Resilience requires sustained action in prevention, preparedness, response and recovery. Therefore, the Commission recommends integrated and equitable models of care, strengthening essential public health functions, community participation and trust, multi-sectoral policies with public-private collaboration, and sustainable and flexible financing.
A commission like this is very important because it brings together individuals who have been working in the health team for a long while, have a different kinds of expertise and experience from different countries in the Americas to look at how can we better improve primary health care.
Additionally, through the Regional Alliance for Primary Healthcare, the Pan American Health Organization, the Inter-American Development Bank, and the World Bank are promoting investment and innovation to achieve more robust and sustainable primary healthcare. Strengthening primary healthcare and resilience are mutually reinforcing. Investing in resilient health systems based on primary healthcare is urgent to save lives and protect the future economy. There is no time to wait.
At the launch of the Commission, President Bachelet, former President of Chile, and the former UN High Commissioner for Human Rights congratulated the initiative of the Commission that addresses issues of great political, economic and social relevance, bringing people together through commissioners with great levels of expertise around these issues. And so now let me introduce some of our commissioners to you that are here today that will present some of the findings for us. Dr. Sarah Bennett from Johns Hopkins University Bloomberg School of Public Health will deliver a short first presentation, and then followed by Dr. Marcia de Castro, Global Health Population from the Harvard School of Public Health. Will follow that presentation from Dr. Bennett. And then we'll have a comment from Dr. Javier Guzman, the Division Chief Health, Nutrition and Population at the Inter-American Development Bank, around the findings of the report. So Sarah, over to you.
Thank you very much indeed, James, and good afternoon, honourable ministers and other distinguished delegates. It's a real privilege and truly exciting to be here this afternoon, given all the work that has gone into this report. I'm not sure if I can control the slides, or if you can just pass the... Thank you. Oh, here we go. Obviously, a large report like this takes a village to create it. So I wanted to very briefly introduce to you the chairs of the Commission, as you can see set out here, and also some of the commissioners, and really to underscore that this was a large effort that depended upon a large and diverse community of people representing indigenous populations, civil society organizations, governments, and obviously international organizations as well, all of whom contributed extensively to the report. The aim of the report is really to advance knowledge and inform decision-making for the future development of resilient primary health care, which you've already heard about. And we set out 3 different objectives for the report. Firstly, to develop a comprehensive policy framework for primary health care resilience. Secondly, to assess the potential consequences of not building resilience into primary health care. And you've already seen some of the findings from that section of the report presented in the brief video where we talked about the economic costs if greater resilience was not built. And then thirdly, to identify potential strategies and policies that countries could pursue in order to improve resilience for future shocks. And we're going to spend much of our brief presentation today focused on this third of the objectives. So this just gives you an overview of the report structure, and really to describe where we're focusing in on, we're really talking about parts 3 and 4 of the report, which present the resiliency framework and policy recommendations, and also begin to set a path forward towards implementation. So starting with the conceptual framework that was used to guide the thinking of the Commission, many of the literature reviews that we did, and the recommendations that came from the Commission. If you look at the center of this figure, you can see that we reflect on 4 phases of health systems resilience. And this is a commonly used framework that looks firstly at issues around prevention and preparedness. How can we prepare for possible shocks, whether these are shocks in terms of climate, shocks in terms of disease outbreak, or natural disasters? And in some cases, are we able to prevent those shocks actually occurring, especially if we're talking about disease outbreaks? Moving around to the next stage of resiliency, we need to think about shocks and our immediate response to these. And so what happens once a shock is detected? How do we communicate that that is occurring to the key stakeholders within the community? And then over time, as we respond to that shock, we need to think about our responsiveness, how we adapt health systems, particularly primary healthcare systems, to continue to provide essential health services throughout the course of the shock, but also how do we contain the shock if possible, so responding to the sources of risk, whether again that's to do with disease outbreaks, where we are looking at essential public health functions, how to ramp up surveillance, and how to communicate to diverse stakeholders. Then the final, and I think often neglected stage of this resiliency cycle is really around recovery and learning. And what we're truly hoping to do here is to build back better. So how can we learn from the shock and make sure that the health systems and primary healthcare in particular grows stronger as we learn about what worked, what didn't work in response to this. So we took these 4 phases of health systems resilience as our core and then reflected on how this connected to primary health care. And we used the WHO framework that really identifies these 3 pillars around primary health care. So first is around integrated health service delivery, and we included within that the essential public health functions. So there's core public health functions that need to be delivered to sustain the public's health. The second domain that we looked at was around community empowerment and participation, reflecting that to be successful in responding to any shocks, we really need to work closely with the community, have a deep understanding of the community response to the shock. And then the third domain that we looked at was around multi-sectoral coordination and response, knowing that many of these shocks are not just shocks that affect the health sector, but ripple throughout the economy, affect education, and affect other sectors as well. So this is the core of the report, but we also acknowledge that primary healthcare systems exist as part of an integrated, broader health system. And so we also wanted to look at how that broader health system is financed, the nature of information and data used for decision-making, and other inputs that may be relevant. And then finally, around all of this, we acknowledged the political environment, the institutions that help support primary healthcare, and the broader socioeconomic context that may influence how primary healthcare responds. And obviously, all of this needs to come together for our ultimate goal of ensuring universal and equitable health access and coverage that promotes and protects health and fosters a stronger economy at the same time. So just to give you an idea about the sort of 4 buckets, if you will, of recommendations that this report sets forward, and which links very closely to the conceptual framework that I've just set out. So in the report, you'll see that our recommendations are aligned around these 4 themes. 1, around integrated service delivery and essential public health functions. Secondly, around community participation and empowerment. And thirdly, around multi-sectoral action. And then we also felt that issues around financing of primary healthcare and health systems, particularly during shocks, was so critical that we wanted to look at that separately. So these are the 4 domains which our recommendations are clustered into. I'm going to talk about the first 2 of these domains and then hand over to my colleague Marcia to talk about the remaining domains and moving forward with implementation. So the first domain looks at integrated service delivery and the essential public health functions. And we divided our recommendations here into 4 main areas. The first is about models of primary care that provide services for all. And we reflected that we really need to have primary healthcare models which are resilient to shocks, and that to do this, we encouraged countries to think about empanelment and linking primary healthcare facilities to enumerated populations. And that means you can then identify who are the vulnerable populations, who may be particularly at risk during a shock, and that also we needed to have interprofessional teams working at this level who can provide not just healthcare services, but who can connect clients to other sorts of services, whether those are social services or other types of required needs. Also, we think that this sort of integrated, close to the community model of primary care provides a basis for community outreach. So we're reaching out to communities to understand how they are experiencing shocks and to prioritize different aspects of the response. And as part of this, we also encourage governments to look at quality improvement mechanisms at this level and ways of understanding users' perspectives on primary healthcare and how the quality of care can be strengthened. The second domain that we looked at in this broad area is around integrated essential public health functions and primary care, recognizing that during COVID-19, in many cases, countries did not fully leverage their primary healthcare systems in order to be able to deliver essential public health functions. So we asked, how can we better bring together primary healthcare services and essential public health functions? And we suggested that in order to do this, we need to better train primary healthcare workers so that they can use data, analyze data and respond to the kinds of issues that they are seeing emerging within their communities. We also suggested that primary healthcare teams needed stronger epidemiological support, particularly in the domains of surveillance. And we looked at examples from Rio de Janeiro, where there was a very purposeful effort to bring together primary healthcare teams and epidemiological surveillance so that primary healthcare teams can help really identify shocks and respond to them. We suggested that there need to be greater efforts to engage communities into health assessments and strong health education programs from the primary healthcare level that really build communication strategies around shocks that are sensitive to the local population. We needed also, the third domain is around maintaining essential healthcare services during shocks. So what can be done to build resilience in the primary healthcare system so that services continue during a shock? And for this, we talk about the importance of digital health and also making sure that primary healthcare workers are trained in terms of how to manage patient flows during an outbreak or similar. The fourth domain in this area really speaks to the link between primary healthcare and higher level specialized networks, knowing that primary healthcare alone is never going to be sufficient in itself to respond to all of the healthcare challenges. So we argue that there needs to be really strong support from higher levels of the healthcare system in order to ensure strong care at the primary level and appropriate referrals level systems between different levels. The second bucket of recommendations speak to community participation and empowerment. And in this area, we have 3 different domains highlighted. One around community engagement, the second around interculturality, and the third around communications and trust. In the first domain, we recognize that to have a successful response to any of the types of shocks the report talks about, we really need to ensure that there is a reliable, trusted relationship between communities and primary healthcare. And so we talk about things like creating regular dialogues, planning opportunities between the communities and primary healthcare providers, ensuring that there are legal frameworks that require participation from the communities in terms of planning for shocks, as well as in terms of oversight mechanisms, and training primary care managers in community engagement activities. Secondly, in terms of interculturality, we reflected on how diverse the cultures within the region are and the need to really build healthcare services and community engagement strategies that are responsive to those diverse communities, whether we're talking about indigenous populations or LGBTQ populations. So in this regard, we talked about developing intercultural health policies that promote traditional medicine, financing intercultural primary care services, and a variety of other recommendations that you can see here. Finally, in terms of building communication and trust, we suggest that health managers co-create with communities sort of trusted communication strategies, and that we develop culturally appropriate multilingual health communications materials. So really thinking about how communication strategies can help build trust and bring the community in. Let me hand over to my colleague Marcia to walk us through the rest of the report.
Thanks, Sarah. Good afternoon, everyone. Dr. Fitzgerald, I'm mindful of time, so I'm going to go really fast. So the third bucket, as Sarah mentioned, is about multi-sectoral action. So here, what we discuss is the need to bring different sectors of the government. Just to name a few, it's health working with education, with social assistance, with security, with environment, and so on. But also the public-private partnerships. It's the use of data, so you can do risk mapping, you can identify geographies and population groups that are under higher vulnerability, and that enables actions to be targeted and directed to those groups. And this multi-sectoral action discussion also explicitly make connections with climate change, talking about climate resilient actions, but also health systems that are more sustainable and more environmentally friendly. We talk a lot about regulation, how oversight is going to be done of those collaborations, so the need for accountability, and also the need to link data from different sources as well. The last one is about financing. And here, the whole discussion is how can we have the right mechanisms and legislation that enables the resources to be available when you have the emergency, but that they can also be disbursed quickly, promptly, and in a way that is accountable and transparent. We discussed the need to have different sources of funding, but also different suppliers, so you don't depend only on one person when you have to do procurement and purchasing of supplies. We talk about the need to find ways of reallocating resources, also including across different sectors in the government. And we also framed this discussion that it goes through the entire resilience cycle. So it's the planning, it's the response, but also the recovery. One thing that is important to mention is that there should also be mechanisms to fund actions that come from the community, and that connects to the other bucket that Sarah mentioned before. So in the report, we recognize that some of those recommendations are very feasible for some countries in Latin America, but not so much for others. Some countries still need to build the essential public health functions before they can think about resilience. So we have this discussion, but recognizing that, we highlight a few things that have to be considered when we're thinking about resilience of primary care. First and foremost, the political economy of the region and of the countries. And when we talk about primary health care reforms, they are political. So you have political interests, you have the health demands, and as long as those are aligned in thinking about an agenda that focuses on equity, so you don't leave anybody behind and you don't perpetuate inequalities that the country has. We talk about the importance of having unions, and that can move forward, some of the reforms as well, and what we call the political champions, people that can advocate for resilience at all levels of decision-making, from the very local all the way up to national and international. When we talk about implementation per se, we discuss the importance of having pilots. And by doing pilots, you're learning, you're adapting, you're fine-tuning, and you're creating this phenomenal laboratory of successful experiences that then can be used to share knowledge, to share innovation. Digital health is here as well. So when we talk about implementation, technology is here, but keep in mind that we need more than technology. We need commitment and leadership. Then on diagnosing, monitoring, and evaluation, we highlight the fact that we do not have a mechanism of diagnosing, monitoring, and evaluating the movement towards primary care resilience. And then we hope that the development of some indicators that are standardized and using data available across countries can help us to make a step forward on this. And the very last thing quickly is that the regional collaboration is an essential action to help move towards resilience, because there is peer learning, there is sharing experiences and sharing innovation. And the very last thing we're going to mention is that we talk a lot about recommendations for resilience of primary care, but we also highlight a few prerequisites to ensure that you have a primary health care that is really functioning. They relate to what we discussed before. So the very first thing is you need to have financing, robust financing that is mostly public and that is sustainable. In thinking about the health workforce, you need to have enough health workforce, well-distributed and well-trained. In thinking about supplies and inputs, you should not just have them, but be able to distribute them across the primary healthcare facilities. And most importantly, you need a strong and committed governance that makes decisions based on science and that can coordinate across different levels of decision-making, but also across different sectors. So that was a very quick overview. There is much more to digest. The QR code was there. So as Thaisa said, we hope that this is just the end of the writing. Now that it's published, it's the beginning of the discussions across and between countries. So hopefully we can make some steps towards resilience primary care. Thank you.
Thank you so much, Marcia and Sarah. And as Marcia indicated, the report is really quite extensive. And so the QR code is actually there if you want to access the full report. It's available for you right now. Javier, let me hand over to you for some comments.
Thank you very much, James. Colleagues and excellencies and partners, first of all, let me begin by congratulating the commissioners, the commission, our colleagues from the World Bank, from the Pan American Health Organization, and the Lancet of the Americas. is clearly a landmark report, and it makes a compelling case that resilience and primary health care are inseparable. And we're not talking about, you need to have a trade-off and decide what to do. And we also very much appreciate that action is based on a very strong business case. So we're not talking about just saving billions, but we're also talking about saving livelihoods, which is the reason for us to exist. So bringing together evidence and analysis and linking that relationship between how resilience must be at the core of primary health care, but conversely, how primary health care is essential for resilience is, I think, very important. And also the how, because this is not just a framework for action, it includes clear, actionable recommendations. And in that how, I wanted to reflect on 4 specific topics. The first one is, when talking about resilience, we're talking about the system and the entry is primary healthcare, but it doesn't end in primary healthcare. And we saw how during COVID, primary healthcare was the point of entry, or wasn't the point of entry to the entire health system and broadly to the response societies would have. So that is the first one. The second one, we think, it's important to look at resilience in the context of outbreaks, pandemics, emergencies, but clearly not only in those contexts. And we'll be, facing other important challenges that will require resilience within the health system. We've heard about migration, we've heard about human resources, we've heard about all other reasons why primary health care must be resilient. And it's important to take that into account. The third thing I want to say is the report highlights very nicely a lot of tools, digital tools that are important. And we believe at the Inter-American Development Bank that digital transformation is essential because the digital infrastructure is the connective issue we have within health systems. And we need to have that connective issue in the best possible way. That is why we are very pleased to be working with you, with the Pan American Health Organization and other partners in the Pan American Digital Highway, which is basically a very interesting concept that resembles, the commitment made by countries here to link the continent from north to south, but in digital infrastructure. So we believe investments in digital transformation are essential for resilience in primary health care to take place. And last but not least, I just wanted to say how financing underpins this work and how we, multilateral development banks, are ready to support countries, work with countries, and work with partners to make this report a reality and to translate recommendations into policies and into a more resilient primary health care. Thank you very much.
Thank you so much, Javier. Thank you so much, Javier, for those thoughtful remarks. Let me now return to the head table. First of all, I'd like to recognize our Assistant Director, Dr. Celie Thomas, who is now joining us at the head table. What we're going to do is we're going to have an interactive discussion now with some of our distinguished members of the head table. And we're going to present some questions, some comments around the report and ask for short interventions, 3 to 4 minutes each, so that possibly we can have 2 rounds of interventions from I suppose, our ministers and public health officials that are living the day-to-day experience of particularly what happened during the pandemic, but more broadly in terms of building health systems based on primary health care. Primero, me gustaría presentar una pregunta para la señora Ministra de Salud de Chile, Jimena Aguilera. Ministra, Chile ha avanzado con la decisión hacia la universalización de la atención primaria de salud desde el inicio de este gobierno. ¿Cómo puede este proceso fortalecer la resiliencia de la APS para que, más allá de garantizar acceso y equidad, en tiempos normales, también actúe como el pilar estratégico del sistema de salud frente a emergencias sanitarias y otras crisis futuras.
Bueno, muchas gracias por la invitación a participar en este panel y por la pregunta. Bueno, para nosotros la atención primaria es el eslabón principal de la respuesta sanitaria y eso es lo que hemos tratado de poner al centro con la política de universalización de la atención primaria. Además, reconocer que la atención primaria en Chile fue traspasada a los municipios hace más de 40 años. Y eso tiene otro elemento que no he visto que ha sido mencionado, que es la democracia. Es el hecho de que la atención primaria depende de una autoridad que es electa por los ciudadanos. Y que esa autoridad, en la medida que reconoce los principales problemas de su comunidad, salud va a aparecer entre esos problemas de la comunidad y eso es un valor agregado. ¿Qué otra importancia tiene el que la atención primaria sea municipal, en el caso de nuestro país, que es el lugar preferencial de la acción intersectorial, que se mencionaba también en el informe? La acción intersectorial no consiste en la reunión de ministros, consiste en el trabajo en el territorio de los distintos actores para la preparación y, por cierto, para el conocimiento de la realidad, para la interacción entre los servicios sociales y los servicios sanitarios, para los servicios ambientales y los servicios sanitarios. Por lo tanto, constituye un lugar ideal para ese trabajo. Para nosotros, la atención primaria universal ha implicado una mejoría porque primero cambia la idea que había anteriormente de tener personas adscritas a la atención primaria por un enfoque en el territorio. O sea, la atención primaria, al ser la universal, se enfoca en el territorio donde está funcionando, se financia con cargo a impuesto fiscal. En Chile tiene una financiación per cápita, por lo tanto hay un incentivo a que la gente se inscriba porque mientras más inscritos van a recibir una mayor cantidad de recursos. En el caso nuestro, además, el Sistema Nacional de Emergencias reconoce que el nivel municipal es el primer nivel de preparación y respuesta para emergencias. Por lo tanto, al incorporar la atención primaria dentro de esa preparación y respuesta a emergencias en el sistema legal de preparación y respuesta, ayuda a tener una visión integrada e intersectorial tanto de la preparación como la respuesta. Los establecimientos de atención primaria, cuando se construyen, estamos tratando de que tengan características que dote de mayor resiliencia en relación al cambio climático, por ejemplo, o a la conectividad digital, que sean un verdadero hub donde en caso de emergencia se pueda recurrir, en caso de sequía, a los depósitos de agua de los establecimientos, a la conectividad satelital de los establecimientos y eso también ayuda a la mayor resiliencia. El proceso que nosotros llevamos a cabo con la atención primaria universal se traduce primero en inscribir a todas las personas dentro de su establecimiento, lo que ayuda a conocerlos y a planificar y conocer sus necesidades. Un ejercicio que es bien difícil, diría yo, es entregarle responsabilidad, que es lo que se hablaba en las recomendaciones de las funciones esenciales de salud pública, el reconocer la inteligencia del nivel local. Eso es muy importante para que sea resiliente. Los sistemas de salud tendemos a centralizar la información, centralizar la inteligencia y entregar acciones a los niveles locales. Y eso no puede ocurrir si uno quiere que el sistema sea resiliente. Tiene que ser capaz de reconocer la inteligencia del nivel local, de dotarlo de capacidades y, por lo tanto, de pararse de una forma más igualitaria con las autoridades del nivel local que son capaces de conocer su territorio y definir sus propios planes. Yo diría que eso es la parte más dificultosa de los ejercicios, viniendo de un sistema que ha sido muy centralizado y que llevamos 40 años de centralización en la atención primaria, pero sigue siendo un ejercicio complejo. Bueno, todos los brotes nacen localmente, todos los incendios, las inundaciones tienen afección local, por lo tanto, el tener una red de atención primaria fuerte permite que si uno esté muy afectado, avance hacia el otro local, digamos, el otro municipio que puede estar ayudando. Nosotros hemos fortalecido capacidades y modalidades de atención en la atención primaria, extensión horaria, operativos en terreno, la telesalud, la gestión digital de las demandas que sostienen la continuidad de cuidados en escenarios de alta presión. En la pandemia se puso en prueba este enfoque. Al inicio no se quería recurrir a la atención primaria como una primera área de respuesta y se concentró básicamente por el temor de lo que estaba ocurriendo en Europa y en Estados Unidos, donde había mucha presión sobre los hospitales, y eso llevó a que las autoridades nacionales trataran de preparar mejor los hospitales y los salubristas y epidemiólogos tratando de que le dieran más importancia a la atención primaria para generar el aislamiento y las medidas de salud pública. Entonces, eso ejercicio que finalmente, bueno, cuando comienzan las vacunas, se revierte, porque en realidad las vacunas, y mi país tuvo un rollout de vacunas muy impresionante, muy rápido, ahí se ve en el fondo la fuerza de la atención primaria. Pero se necesita ver antes, no solo en las vacunas, sino que antes, el entender cómo la función esencial de salud pública se desarrolla de la atención primaria, que si el primer nivel tiene la capacidad de detectar y responder, las emergencias no escalan o se controlan de mejor forma. Y eso se aprendió, pero no se aprendió lo suficiente en la parte de preparación y primera respuesta a situaciones de emergencia. Se aprende más en la fuerza que tiene, la cobertura que tiene la atención primaria en mi país, que llega a todos los territorios. Nosotros hemos avanzado hacia un modelo integral de cuidado centrado en las personas y a la integración de los servicios sociales y sanitarios, a la integración del sistema de información del Ministerio que ve el desarrollo social con el Ministerio de Salud, de manera que la persona, cuando es atendida, uno pueda verla en su integralidad y también direccionarla. A veces las burocracias nuestras tienen muchos derechos para las personas, pero que son difíciles de entender por las personas. Y uno lo está acogiendo para el sistema de salud, pero tiene un derecho a pensión que no ha reclamado, tiene sistemas de apoyo para la vivienda que no ha reclamado. Entonces, esa integralidad se puede analizar y solo se puede llevar en una escala de atención primaria. A nivel central es imposible, es necesario bajarlo porque ya estamos en una condición de desarrollo que permite tener una serie de herramientas que están en el nivel local. Nosotros hemos reforzado la participación comunitaria, lo mismo. No puede haber participación comunitaria que no sea en el nivel local, en el primer nivel. Si no, no existe en realidad, porque si no es una persona que nadie sabe quién la eligió, que representa a quizás qué grupos que uno no conoce. En cambio, en la atención primaria, al trabajar con las comunidades presentes, uno tiene un mapa de los actores. Cada persona tiene un mayor valor para trabajar en su misma comunidad, y lo mismo reforzar el hecho de que se está en un sistema en el cual las autoridades son electas, ayuda a que esa participación social tenga mayor valor, incluso para el que dirige la atención primaria. Y en quinto lugar, nosotros hemos impulsado con la atención primaria universal la transformación digital, la interoperabilidad de registros, como mencionaba, la expansión de los sistemas de telesalud, incluso el desarrollo de un primer servicio de salud virtual, que presentamos una ley que se está discutiendo en el Congreso y que habilita a tener alertas tempranas y coordinación interniveles. Yo creo que nosotros estamos viendo una revolución del sistema asistencial por la tecnología y la atención primaria va a ser el lugar donde se va a llevar a cabo esa revolución por el acceso a la tecnología de información, la conectividad digital, la robotización, la inteligencia artificial. Pero tenemos que ser capaces de desarrollar esas capacidades en el primer nivel, con más democracia, en una forma más horizontal de gobernanza con el resto de los niveles del sistema de salud, y que reconozca la importancia y la inteligencia de cada uno de esos niveles para actuar. Muchas gracias.
Muchas gracias, ministra Aguilera, para compartir la experiencia de Chile en estos últimos años y además por su reflexión respecto a la parte más perspectiva. Tal vez si tenemos tiempo vamos a regresar sobre el tema de salud digital, pero vamos a continuar después invitando al señor Bernards, Minister Bernards, from Belize. We heard from Chile, from Minister Aguilera, that one of the most important but challenging issues related to the implementation of the essential public health functions and its relationship, particularly at the, not so much at the central level, but at the community level. Belize is a small state which is highly exposed to climate shocks. And it represents the significant vulnerabilities that we see across the whole Caribbean in that regard. Politically, how do you see the integration of the essential public health functions within primary health care as a strategy that can really promote and strengthen resilience within the health sector and more broadly within society?
Thank you for the opportunity once again. And of course, indeed, Belize, as a small Caribbean nation and part of the Central American region, lives with that reality in terms of the climate shocks. We know we confront hurricanes, floods, and the rising seas that are now affecting us. And this can disrupt not just our economy, but our very sovereignty. And I think that for us, one of the things that we have said, that resilience is not a luxury, but it is survival. And that is why we see the integration of the essential public health functions into primary health care as a sovereign political strategy. In October of 2023, one of the steps we also took was to remove user fees from all primary and secondary care services, for the mere fact that we want to ensure that there's access to universal health care. And when we embed surveillance, preparedness, and health education and environmental health directly into our public health, primary health care, there are three things that I think had happened, and in our experience. One, we tend to reduce external dependency. Our communities, for example, as you know, becomes the first line of defense. And so we also, what we did in terms of ensuring that our community health workers, who are the first point of contact, we increased their stipend so that we could get more out of them as well. And so when we are able to then respond more quickly to outbreaks and disasters without waiting for outside help, and that requires us to have been able to train our people, and with the support of PAHO, we were able to do a lot of these things. I think that as well, in terms of when I mentioned about reducing external dependency, this also would it preserves autonomy in decision making within the country at the most critical moment. Secondly, when we ensure that we do these things, as I said, embed our surveillance and preparedness and health education and environmental health, the second thing I think we do is also strengthen social cohesion, because a health system that is rooted in primary health care, it builds trust. It builds trust between governments and citizens, and we recently rolled out our National Health Insurance Services, which focuses on primary health care. And that trust is the foundation, I believe, is the foundation of political stability. And it becomes even more important when people are under stress from climate events. And the third thing when doing that, I believe that integration allows us, enables rapid and more efficient responses. And so our decentralized primary health care system can also maintain these essential services, even in the middle of a storm, so that we could ensure that there's continuity and protecting our people from secondary crises. I believe that the strategy used was also cost effective. It maximizes infrastructure, existing infrastructure, engaging our communities and partners and true partners, and ensuring that when external aid is needed, it is channeled effectively under national oversight. And so in Belize, our primary health care teams, doctors, nurses, our pharmacists and community health workers, they all work hand in hand with surveillance units to keep this system adaptive and inclusive. So for us, the integration of essential public health functions into the primary healthcare is not just about health. It is also about defining sovereignty, maintaining stability, and of course giving our people confidence that even under the hardest conditions, their government is present, prepared, and capable. And that has been the priority of our government under Plan Belize 2.0, and the Prime Minister who, as the leader of the country, has also ensured that primary healthcare, health services is of priority in our country. And the budget for the last 2 years have been increased to ensure that we are able to keep our primary healthcare services at a level where we can offer better service to our Belizean people.
Thank you so much, Minister Bernard. You really highlighted, I think, one of the key elements, which is the foundational support of community health workers and how they integrate within a system to ensure that resilience within primary health care. Agora, quero passar a palavra a nossa vice-ministro, secretário executivo do Brasil conectado aqui, Dr. Adriano Massudo. Boa tarde, Adriano. Obrigado pela sua participação aqui também hoje. E o Belize destacou a importância das agentes comunitários de saúde dentro do marco do Sistema Único de Saúde, que tem uma rede construída em base à estratégia de saúde familiar, uma estratégia que já está bem implantada no Brasil desde muitos anos. Quero talvez plantear uma pergunta para vocês sobre como o Brasil está fortalecendo, dentro desse marco, a vigilância sanitária e alerta precoce em situações de emergências sanitárias, também para manter o funcionamento dos serviços de atenção primária, mas também reduzindo as filas de espera e gerenciando os encaminhamentos para atenção especializada, que sabemos que é uma prioridade para o Brasil nesse momento. Adriano, para você.
Bom, boa tarde, muito obrigado, James. Queria te cumprimentar em seu nome e cumprimentar todos os participantes desse importante painel. Quero parabenizar o Banco Mundial, a OPAS e os membros da Comissão Lancet, do qual tive o orgulho, o privilégio de poder fazer parte. Eu, como um pouco ansioso, a Márcia disse, agora que está publicado, vamos implementar. Eu acabei começando a implementar um pouco antes, porque tomei posse no Ministério da Saúde, com muito orgulho, compondo o time do ministro Padilha e antes da ministra Anísia, no governo do presidente Lula. Mas não posso deixar também de fazer um lamento, em nome do governo brasileiro, expressar o nosso profundo desacordo com as inaceitáveis restrições de movimento impostas pelo país anfitrião dessa reunião ao ministro de Estado da Saúde, Dr. Alexandre Padilha. Não fosse por isso, ele estaria aí presencialmente representando o Brasil nessa sessão informativa e no conselho diretor da OPAS. Mas quero, enfim, dizer que, apesar disso, né, o Brasil tem muito a comemorar com os 35 anos de implementação do nosso Sistema Único de Saúde, que foi celebrado na semana passada. E a estratégia Saúde da Família, ela é totalmente conectada com a implantação do nosso Sistema Único de Saúde. Ela foi a estratégia para a gente garantir acesso universal e integral à população brasileira, um território continental com grandes diferenças regionais. E a gente apostou num modelo bastante inovador. Nós temos já 25 anos de experiências de implantação de equipes multiprofissionais, que são as equipes de saúde da família, que realizam ações de cuidado assistencial junto com ações de saúde pública. Essa integração entre a clínica e a saúde coletiva para uma população de um determinado território é central para o alcance das ações e levar ações ao conjunto da população. Além disso, a gente veio avançando gradativamente em garantir suporte especializado às equipes de saúde da família por meio dos núcleos de apoio à saúde da família. Além disso, nós temos investido fortemente em tecnologia de informação e saúde digital. Hoje, 90%, quase 90% das nossas equipes de saúde da família, no território continental como o Brasil, mais de 50 mil equipes de saúde da família, já contam com prontuário digital. Eu estou dizendo que tudo isso é muito importante para que a gente possa fazer com que essas equipes, do Iapoque ao Chuí no Brasil, do norte ao sul do nosso país, possa ter suporte especializado, seja para ações de saúde pública, seja para questões de cuidados especializados, com suporte de profissionais especialistas. Nós temos incentivado e investido fortemente a partir dessa rede no uso da telesaúde. A telesaúde, tanto para dar suporte com teleconsultas realizadas nas unidades básicas de saúde, mas também com teleconsultoria, permitindo que as equipes de saúde da família se integrem tanto com as equipes de vigilância em saúde, e assim os alertas verificados possam servir de suporte para respostas, como também para discussão de casos que precisem ser encaminhados para atenção básica, para outros níveis de cuidado. Eu tive a oportunidade de já ter sido secretário de saúde na Secretaria de Curitiba, onde implementamos isso há 10 anos atrás, e a gente viu que a capacidade de redução de encaminhamentos da atenção básica para atenção especializada chega a próximo de 70%, dando muito mais eficiência na organização do nosso sistema de saúde. Hoje, o telesaúde é um componente fundamental do programa Agora Tem Especialistas, que é uma das prioridades do governo do presidente Lula e que traz um conjunto de inovações para reorganizar a atenção especializada. Todo o conhecimento, a experiência que nós conseguimos implementar na atenção básica, na atenção primária, com equipes multiprofissionais, nós estamos levando para a atenção especializada, organizando cuidados integrados para substituir a grande fragmentação que ainda existe para uma organização de cuidado integrada, em rede, com responsabilização. Então, essas são as ações que nós estamos realizando e o fortalecimento do sistema de saúde, do SUS, o fortalecimento da atenção básica, o fortalecimento da integração com o suporte de cuidado especializado, mas também suporte das equipes de vigilância em saúde fazem com que o nosso sistema de saúde esteja mais preparado para o enfrentamento dos desafios que estão colocados, as emergências climáticas. Não quero perder a oportunidade de dizer que a gente tem uma oportunidade ímpar de discutir a preparação do sistema de saúde para o enfrentamento do Pará aqui no Brasil. Pela primeira vez, a COP vai pautar a saúde como um eixo, fruto das grandes desafios que estão colocados no mundo, mas também da ação da OPAS, da Organização Mundial de Saúde, para levar esse tema adiante. Então, agradecer muito a oportunidade de poder estar aqui contribuindo com esse debate e continuar no desafio da implementação das ações que estão colocadas nesse excelente relatório. Parabéns a todos.
Muito obrigado, Dr. Massudo. Também para notar que Dr. Massudo Adriano foi também membro da comissão antes de ocupar a posição da Secretaria Executiva da Atenção Especializada no Brasil e agora como secretário executivo do Ministério da Saúde no Brasil. Obrigado. Ahora vamos a pasar a doctora Santa María de Panamá. Una pregunta más que nada en función de lo que hemos escuchado, la importancia de los socios estratégicos que son clave para apoyar y acompañar estos procesos en un país. Sabemos que Panamá firmó el acuerdo de la alianza para entrar en la alianza para atención primaria y salud ayer con la OPS, con el BID y con el Banco Mundial, con la presencia del señor ministro de Salud de Panamá. Doctora Santa María, entonces, ¿cómo visualiza el rol de esta alianza en la coordinación de estas inversiones que hemos escuchado que son tan importantes a nivel del país para fortalecer los sistemas basados en la APS? ¿Y cómo se puede resultar, entonces, en función de asignaciones más estratégicas, una APS más sólida y una mayor resiliencia de los sistemas de salud en Panamá?
Agradezco la invitación y la pregunta. Y, bueno, ciertamente, luego de la pandemia, se ha posicionado la salud, la protección social en otros sectores como el económico, y esto ha impulsado los diálogos entre los Ministerios de Economía y Finanzas y los Ministerios de Salud a fin de evaluar y de abordar conjuntamente las debilidades estructurales en relación a los sectores de la salud y de protección social. En ese sentido, la Alianza para Panamá representa una plataforma clave para poder articular y para poder ordenar todas las inversiones en función de los esfuerzos nacionales e internacionales. Es decir, que nosotros valoramos o visualizamos el rol de esta alianza como un mecanismo o un espacio de alineación estratégica en donde se integren las prioridades del país a las capacidades técnicas y financieras de nuestros socios, OPS, Banco Mundial y Banco Interamericano de Desarrollo, para que las inversiones, garantizar que las inversiones no se dupliquen, sino que se complementen y el impacto se multiplique. Entonces, la alianza concretamente permitirá, primero, ordenar y coordinar las inversiones en función o en torno a un plan de fortalecimiento de la atención primaria de salud para fortalecer los recursos externos en función de manera coherente con los objetivos estratégicos de nuestras políticas de salud, pero también en función de las brechas que hemos identificado, por ejemplo, en la evaluación de las funciones esenciales de salud pública, y que tenemos un plan de acción y que requiere el acompañamiento y la movilización de recursos externos. También, lo segundo, optimizar los recursos, porque eso nos va a permitir a nosotros poder analizar las brechas, las áreas críticas, pero en función de poder ver cómo la cooperación externa o estos recursos externos tienen un mayor retorno social, como por ejemplo en la red de servicios, en el desarrollo de recursos humanos y en la digitalización de la atención primaria de salud. Puedo decir que en Panamá nosotros hemos implementado el traslado de muestras por medio de drones, la telemedicina, también el expediente electrónico, extramuros, la capacitación de parteras. Lo tercero, eso va a aumentar la resiliencia de los sistemas sanitarios, porque si nosotros invertimos en atención primaria de salud, estamos invirtiendo en la resiliencia de los sistemas sanitarios, porque estamos fortaleciendo la capacidad de respuesta, pero desde una base diferente, desde una base comunitaria en donde haya un acceso oportuno de calidad y eficiente a los servicios de salud. Y cuarto, eso promueve la innovación y también la transferencia del conocimiento, facilitando que Panamá pueda incorporar buenas prácticas, no solamente a nivel regional, sino también a nivel global. Recientemente, Panamá lanzó la Estrategia Nacional de Transformación Digital para la Salud, con el acompañamiento técnico y financiero de la Organización Panamericana de la Salud. Y Panamá también es vicepresidente de la Red FES, de la Red de Funciones Esenciales de Salud Pública, en donde vamos a compartir buenas prácticas y experiencias de los países en cuanto a los planes de acción que nosotros estamos implementando para enfrentar esas brechas que han sido identificadas y que a final de cuentas fortalecen la atención primaria de salud y la resiliencia de los sistemas sanitarios. En resumen, la alianza para nosotros es un mecanismo de articulación, de transparencia, de eficiencia, en donde nosotros podemos garantizar que cada dólar invertido en la salud contribuye al fortalecimiento de la atención primaria de salud y de ese modo también va a contribuir a hacer un sistema de salud más resiliente, más equitativo y más sostenible para beneficio de nuestra población.
Muchas gracias y muchos éxitos también en la participación y la conducción de esta mesa consultiva que fue lanzado ayer por la Alianza. So unfortunately, we won't be able to have a second round of questions because we all need to be back in the main room in 20 minutes. So what I'd like to do now is to move to some closing remarks from our co-chairs of the Commission. First of all, from Christian Herrera, who's the Senior Health Specialist of the World Bank and has really been driving the work of the Commission, driving us all to the finalization, the publication of the work today. Christian, over to you.
Muchas gracias, James. Estimados ministros, ministras, autoridades, colegas, amigos también. Lo primero, what a journey this has been. Permítanme ser un poco informal también en estas palabras de cierre. Ha sido una gran tarea, más de 2 años, donde aquí mismo en este edificio con Ernesto nos juntamos a conversar y surgió esta idea. Contactamos a Thaisa y Thaisa rápidamente también se sumó a este proyecto. Entonces agradecer, es lo primero, sin duda, ¿no? Agradecer Jaime, Tania, el apoyo constante siempre, ¿no? al proyecto desde el Banco Mundial. James, Ernesto, Natalia, estoy nombrando algunos, nomás quienes han estado más involucrados, pero muchas gracias a través de nuestras co-chairs acá, Marcia, Sara, a través de ustedes, a toda la comisión, ¿cierto? Y al secretariado, que muchas veces hicieron el trabajo pesado, ¿sí? De seguro, varios de ellos, ellas están conectadas y bueno, por supuesto, Adriano, que como él decía, él comenzó como academic co-chair, ¿no? Y pasó ahí al ministerio, pero por supuesto también representa lo que queremos hacer ahora, que es pasar a la práctica, a la acción, como se decía. Y en eso, 3 mensajes muy rápidos. Lo primero, urgencia. El título de nuestra comisión habla de esa urgencia. No hay tiempo que esperar porque los shocks, las emergencias están ocurriendo ahora. No es que vayan a ocurrir más, ya están ocurriendo más. Entonces, es necesario mantener ese sentido de urgencia y que por las múltiples cosas que ocurren, ¿no? de esto va perdiendo un poco la prioridad y es difícil mantenerlo arriba. Entonces, urgencia con respecto a la atención primaria, urgencia con respecto a resiliencia, que como bien decimos en la comisión, van de la mano. No es uno o lo otro, van de la mano. Si se fortalece atención primaria, se fortalece resiliencia y viceversa. Lo segundo, colaboración. Esta comisión es un claro ejemplo de cómo la colaboración nos puede llevar a más. Esa colaboración en estos tiempos está siendo desafiada, ¿sí? Y nosotros creemos que efectivamente la colaboración es lo que nos puede llevar a más. La alianza es un gran ejemplo. Aquí está Javier por el BID. Bueno, el director, la doctora aquí, James, todos representando a OPS, BID, Banco Mundial, nosotros siempre en el espíritu de esta colaboración, la colaboración público-privada también, importante que nosotros también la mencionamos, tiene que estar los actores también privados con y sin fines de lucro, cómo contribuyen al bien común, al bien público con esto, ¿sí? Para teniendo eso como muy claro. Y lo último en colaboración, lo que decía la doctora Santamaría, lo mencionó rápidamente, pero la importancia que tiene la conexión de salud con Hacienda, ¿sí? Esa conexión nosotros, bueno, desde los bancos, ahí también Javier estará de acuerdo, es clave, es muy importante, pero a la vez muy difícil. Y por eso también es que nosotros como comisión quisimos poner estos datos en números económicos, para poder hablar y facilitar ese diálogo con el sector Hacienda. Entonces ahí esa colaboración muy importante. Y lo último, acción. Necesitamos pasar a la acción, ¿sí? Eso es muy clave y aquí estábamos hablando también por interno qué otras autoridades estaban presentes de los países en esta sala, porque es con ustedes, ¿no? Es con las ministras, ministros, autoridades de salud pública, de los sistemas de salud con quienes esto tiene que ocurrir. Y ese es el siguiente paso, ¿sí? Siguiente paso de que esto ocurra Y luego con el Lancet, para mencionarlo también, de hacer el monitoreo con la academia, de ver cómo esto avanza, si avanzamos en la dirección correcta o no, y esperamos dar ese seguimiento. También me atrevo a decirlo ahí, Jaime, Tania, de poder hacer eso en adelante también y impulsarlo desde el banco y en colaboración, por supuesto, con todas las otras agencias, como bien decía. Así que cierro agradeciendo nuevamente desde el lado del Banco Mundial y seguimos en esto juntos.
Thank you very much, Christian, for those final remarks. And then over to Ernesto Baccolo, who's our Unit Chief of Primary Health Care and Integrated Service Delivery from the Department of Health Systems Service here at PAHO as co-chair.
Gracias, James. Yo creo que quedó muy claro tanto en el marco como en las recomendaciones que hacer y obviamente en el título de cuándo hacerlo, ¿no? Es ahora. No podemos postergar este proceso, más allá de los antecedentes, los avances de algunos países. La urgencia es clave, pero hay dos elementos que me gustaría complementar y que son parte de los mensajes del propio reporte. También el reporte incorpora para mí una noción fundamental, que este camino es un camino largo, no es un camino corto ni simple, no tiene que ver con acciones aisladas. Cuando estamos hablando de atención primaria de la salud, pensamos a una atención primaria de la salud, como dice nuestro director, moderna, con capacidad resolutiva, con capacidad de coordinar incluso no solo el sistema de servicios de salud, sino también integrándose a esta noción de sistema de salud resilientes. Y por eso el camino tiene que ver con cambios estructurales. Y por eso hay que pensar que ese camino requiere no solamente recursos, incorporar la noción de sustentabilidad de un camino que implica muchas complejidades en el futuro. Y eso para mí está relacionado también en cómo navegamos este camino. Y para navegar este camino, para recorrerlo, para preguntarnos el cómo y no solamente el qué, hay que incorporar una noción, como creo que lo había dicho Jaime, el director previamente, un análisis de economía política. Y esto implica no solamente pensar los obstáculos de este proceso, pero también los facilitadores de este proceso. Y es por eso que tenemos que estar pensando, para mí, en tres dimensiones fundamentales. En primer lugar, instituciones fuertes que pavimenten este proceso. Obviamente, la doctora Santamaría y muchos otros mencionaron el componente de funciones esenciales en salud pública. Para nosotros, cuando hablamos de instituciones, hablamos de funciones esenciales en salud pública también. Y es fundamental incorporar esto como una agenda central. Pero aparte de instituciones, hay otro elemento que yo quisiera destacar, es casi obvio en este contexto, que tiene que ver con los actores. Con los actores no solamente a nivel regional, a nivel global, sino a nivel nacional y subnacional. Y me estoy refiriendo a alianzas no solamente regionales, sino a alianzas que aterrizan en los territorios. No me refiero solo a actores comprometidos, también cómo alinear los intereses de los actores, ya sean públicos y privados. Y cuando digo público me refiero obviamente a las autoridades de salud, a las estructuras del Estado, pero cuando hablo de privados me refiero al conjunto de actores que forman parte de la sociedad civil. Y por último, la construcción de narrativas que nos permiten esta coordinación que planteaba previamente. Cristian.
Así de cansado
a mí me parece que cuando pensamos en narrativa yo creo que hicimos muchos esfuerzos en la comisión, es incluso darle significado y aclarar ciertos conceptos fundamentales. Estamos hablando de atención primaria de la salud, qué significa, cuál es su rol, el rol de la relación entre una atención primaria fortalecida y una resiliencia del sistema de salud. Cuando hablamos de sustentabilidad, no solo es una sustentabilidad del financiamiento, es la sustentabilidad política e institucional de todo este proceso. El tema de red de servicios de salud, el tema de barreras al acceso a los servicios de salud, fueron todos elementos tratados en este reporte. Y yo quiero terminar, no empezar, como vos decías, con agradecimiento. Para mí fue un camino muy difícil, pero muy, vamos a decir, divertido, excitante, este trabajo. Quiero agradecer a todos los equipos técnicos, al Lancet, a Taisa por creer en nosotros hace 2 años atrás con esta propuesta. Obviamente a todos los equipos técnicos, y quiero enfatizar, porque la idea fue del Banco Mundial. Así que yo quiero agradecer mucho al equipo del Banco Mundial, quiero agradecer estas discusiones iniciales, obviamente a los 2 co-chair, también a Manuela, que está conectada y está escuchándonos, pero también a Tania y a Jaime, que nos han apoyado en este proceso. En el caso de OPS, toda la estructura de la OPS, ¿no? Desde James, el director, las oficinas de país. Los Estados miembros fueron un rol fundamental de este proceso, porque no solamente compartieron sus experiencias, sino que habilitaron muchos estudios de casos dentro de este proceso. Sin ellos, esto hubiese sido imposible. Pero también, en el caso de OPS, a todos los equipos técnicos, a Natalia Houghton, que también fue co-chair, y que sin su participación esto hubiese sido imposible. Bueno, por supuesto, al BID, que también se incorporó dentro de este proyecto y que tus comentarios adquirieron muchísimo sentido, Javier, cuando lo decía. Yo creo, sinceramente, que en este proyecto en particular no solo fuimos alianza para la APS, fuimos un solo equipo. Y me imagino el camino hacia adelante, que sigamos así, porque sin un equipo con esta integración hubiese sido imposible lo que hemos pasado y lo que tenemos que llevar adelante. Gracias.
Thank you very much, Ernesto. And that brings us to the end of this event. I really want to thank all our ministers present, our distinguished speakers, guests, the commissioners, teams from the World Bank, PAHO. It's been a wonderful event, and I think, as we've heard, this is not the end. This is the beginning. We will be beginning with now following on from this with a series of activities around diffusion, communication, and working with our countries around this report to see how we can now move forward to the implementation of its recommendations. Thank you very much, and have a very good afternoon.